Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a heart cataract with small pupil, microcornea, and Coloboma Iris and Coloboma choroid. Let us observe this surgery. This is the main incision at around 11 o'clock with a 2.8 millimeter steel keratome on the posterior aspect of the limbus, and now a side port is made on the left side of the main incision about 3 clock hours away. And now an air bubble is injected into the anterior chamber. You can see that the pupil has not dilated well. So my plan is to inject the dye and a bit of adrenaline to see if the pupil dilates. Otherwise, my plan is to use iris hooks. But as soon as I inject adrenaline, the pupil starts dilating. And now see the magic. Within few seconds, this is real time, within few seconds the pupil dilates to about 6 to 7 millimeter. Very good dilatation in few seconds. So I start doing capsulorhexis with the help of this utrata forceps. There is a zonular dehiscence at 6 o'clock, but rest of the zonule is okay, quite strong. So I may not have to use a capsular tension ring in this case. So rhexis is being done slowly without any jerky pull, and here it is, the rhexis is complete. Size of this rhexis is about 5 millimeter. Now hydrodissection is done. The central part of this nucleus is quite hard. The peripheral part is not so hard. Visco is injected, and now I introduce the Phaco needle into the anterior chamber with its bevel down. Vacuum was set at 450, and I find that the cortex is quite sticky, and there is zonular dehiscence at 6 o'clock, so I don't aspirate any cortex in this case. Just want to do direct chop in the submarine technique. Bury the teeth, go through the substance of the nucleus for a distance, and chop. Rotate the nucleus and chop it here. Now as I try to emulsify this piece, I can see a gap at 6 o'clock. So I stop and fill the bag with the lens matter and then emulsify this free nuclear piece. And now I hold the other heminucleus and chop it. Rotate, chop this piece. And now my plan is to emulsify the nuclear pieces with low vacuum. I have decreased the vacuum to about 350 at this moment. And very slowly I am emulsifying the pieces. I am not in a hurry. I just want to do a nice job for this young gentleman. The patient is about 45 years old. This is the last piece. At this time I have decreased the vacuum further to about 250 and emulsifying this last nuclear piece, and I keep a sheet of epinucleus as a cushion between the posterior capsule and the nuclear piece. And now I decrease the vacuum further for this epinucleus. I keep the vacuum at 150, flow rate 25, and manage this epinucleus. And it was managed okay. I come out, inject visco to fill up the anterior chamber and the capsular bag, and now I'm going to remove the cortex. I want to remove the 6 o'clock cortex later because there is zonular dehiscence. I want to clean the cortex from other parts first. So cortex from 5 o'clock is being removed at this time. And now I come out at this time. I want to fill up the antechamber and bag again with visco, and then I'm making one more side port at 7 o'clock. There was only one side port till now, and now there's another reason to make this side port at 6:30 or 7 o'clock. We're going to see that in a short while. So the cortex from the right side is being removed. Now I go through the 6:30 o'clock side port and remove the cortex from 12 o'clock. Now fill the antechamber and the capsular bag again with visco, and then implant a hydrophilic acrylic single piece intraocular lens in the capsular bag. The patient could not afford a hydrophobic multi-piece intraocular lens. The haptic is placed at 6 o'clock to give some amount of support to the dehiscent area of the zonule. And now the visco is cleaned first with Simcoe. That part has been edited out, and then with this bimanual irrigation aspiration. Visco from the bag is being removed in this way. The irrigation goes behind the IOL and the aspiration remains over the IOL or at the edge of the lens, and the visco is removed from behind the intraocular lens. And now my plan is to do sphincterotomy for this patient. So I inject air, then inject pilocarpine under the air, wait for few minutes, 2-3 minutes, and then replace the air with visco. And now I take a Vanna scissor, go through the 7 o'clock side port. We can use a micro scissor if we have a smaller side port, and do this sphincterotomy. This has been done because in normal situations the upper border of the pupil comes down and covers the visual axis. And now this is the final cleaning of visco. We are towards the end of the surgery. The side ports are closed by stromal hydration. In such cases, if the zonular dehiscence is little more, we can use a CTR in the middle of the surgery. This is the final lavage of the anterior chamber. See, the pupil has constricted, but still the upper margin of the pupil is not covering the visual axis. Thank you very much for your attention. Hope this video will help you in developing your surgical tips. It will give you many tips to manage such cases. Be a great surgeon and serve your patients with love, respect, compassion, and great surgical competence.